Today we're doing a simple upper second premolar implant. We're using Z Systems Z5C implant, a two-piece all ceramic tissue level implant. So today our goal, can we see the film here?
Yep.
Here's a panoramic view of our existing condition. So we can see our missing tooth there. And let's jump from that to the narrow cone beam CT. And we've already planned our implant placement. And we can see we have a 4 by 10 millimeter implant selected. So again, we have a 10 millimeter implant length. Really, it's closer to 12 millimeters if you include the polished collar. And the collar tapers out, flares out. So this shoulder of this implant will be closer to 5 millimeters than 4. It's 4.8 millimeters. So we'll pretend it's 5 in treatment planning considerations. And this is our challenge for the day. So here we can see we have plenty of bone height. So a 10 millimeter implant is perfect for this site. We could use an 8 millimeter implant, and that would also be good. There's no reason that we couldn't use an 8. Sometimes in the posterior, if instrumentation is difficult, we're happy to use a 8 millimeter long implant instead of a 10. And when we look in cross section here, we can see that we have an unusually wide ridge in this premolar region. So again, using a 4 millimeter implant is not a challenge. Here you could say, well, let's just for fun, let's change this implant to a 5 millimeter implant. Let's see what that looks like. And we'll switch it to a 5, and we see that we really have enough buccopalatal width for a 5 millimeter implant. But the bigger issue is that between these teeth, between the adjacent teeth, that's where we really don't have space. So again, we're really selecting our implant by not what's the biggest implant we can place in the available bone. What we're trying to set up is the ideal restorative solution. So we're working backwards from the restorative result that we want. So again, while we could put a 5 millimeter implant in here, the problem is we get too close to the adjacent teeth. So we're going to scale this back, and we're going to do kind of the normal diameter, or 4 millimeter diameter implant, if you will. And we look at this 4 millimeter implant. What we have drawn here, I don't know if you can see it on camera, but we have a 2 millimeter box drawn around the implant where all these lines are 2 millimeters away from the implant itself. And this, we can adjust the size of that box. For example, making it 1.5 millimeters away would be a good choice also, because that's the minimum distance that we want between our implant and adjacent tooth root. If we're placing consecutive implants, we want 2 millimeters of space between consecutive implants. And this is so that long term, the bone between our implant and the adjacent tooth, or the adjacent implant, so that that bone is stable, so that we don't progressively lose bone height. Because in our treatment planning, we're not just trying to treatment plan what the crown's going to look like the day of delivery, but we're trying to treatment plan what is this crown going to look like 10 years from now. Is it going to have bone loss around it? Are we going to impact food? Are we going to impact the health of the adjacent teeth? So we're doing a long-term crown down treatment plan, crown down treatment planning. It's implant dentistry is a restorative specialty with a surgical component to it, and we're planning the restoration that we want, and then we're working our way backwards to support that ideal restoration. In this case, a 4 millimeter diameter implant is clear, and we could use an 8 or a 10 millimeter implant. If we really wanted to get a little tricky, we could use a 12 millimeter implant. The thing about using a 12 is that it gives us a little less buccopalatal angulation flexibility to match up the occlusion as well as we would like. And number two, if we decide we want to countersink the implant just a little bit to help us modify the emergence profile, it doesn't allow us the latitude to do that as easily. So again, I think a 10 millimeter length is ideal here. And if you used an 8 millimeter implant in this scenario, I think that would be absolutely fine. We'll give you an A+ on that also. So that's what we've got. So if we look at our final image down here, we can see that the ridge crest, we see the ridge crest is tapered off here, just up at the top of the implant. And as we go down, we see that the ridge pretty quickly expands in width and becomes really a pretty ideal ridge form for our implant. So we literally see the threads rotating around, and then we see our safety zone below the sinus. So coming back, here's the apex of our implant right there, and we're riding up the implant till our ridge narrows off, and then we see the implant get wider at the shoulder, taper out to a 4.8 millimeter, and we still have plenty of space between our adjacent teeth. So our implant positioning is very important here, because again, we do have about 1.5 millimeters to 2 millimeters of space on either side of this tooth. The idea of an implant restoration is to design our implant placement so that the patient's occlusion, their function, is functioning on this restoration in a way that puts a compressive load on our implant. So we want our implant crown to be well centered over the implant without large buccal overhangs, large interproximal overhangs. So if our implant's way too close to one of these teeth, or we have it off to the palatal and angled to the palatal, these placements are going to necessitate big overhangs or ridge lap designs. And when the patient's functioning out to the side of the implant rather than over the top of the implant, then we wind up putting a shear load, shear forces on our implant, and something's going to fail. An opposing tooth, this crown, the abutment, the implant itself. And with the titanium implant system, what we usually see as a pre-failure event is we see the screw loosened, and then we have a loose crown abutment complex or a loose screw-retained crown, or worse things happen. We get deformation of the implant or the abutment. So again, we're trying to compressively load our implant with the ideal restoration, in this case a single tooth premolar crown that's going to be cement retained by a cemented abutment into our ceramic implant. So positioning of our implant is important to satisfy this. So this is our patient workup. I'm going to enlarge this picture here. So now you can see very clearly our implant, and then what we like to do is rotate the patient around our implant just to make sure that we're adequate distance from adjacent teeth, that we're not into the sinus, that we're not perforating the buccal plate, that our implant angulation is acceptable, and that the size of implant we selected is acceptable. So again, we've rotated 180 degrees. We'll take it back to where it was, and this looks fine. And again, our little default 2 millimeter box helps us position our implant and make sure that this is what we want. At this point, we have the option of either making a surgical guide, and we can make a surgical guide in one of two ways. We can make a simple one where we have a hard acrylic surgical guide, drill a hole through the surgical guide on a patient model, and transfer that to the mouth. When we do that, we typically just use that for the pilot drill so that we get we establish a proper positioning of our implant and a proper initial angulation, and then we do the rest of the drills without the surgical guide. So we use those surgical guides just for a starting point. Or we could do a guided surgery where we use any manufacturer's surgical guide that we want, typically a keyless surgery drill kit, and we will use the surgical guide to drill through for our osteotomy, and we'll go all the way to the very last drill. And then the very last drill, whether we're placing a 4 millimeter diameter implant or a 5 millimeter diameter implant, we'll use the Z Systems drill, and without the surgical guide, just following the pre-drilled hole, and then we'll place the implant again with the surgical ratchet by Z Systems, again not using the surgical guide. So when we do guided surgery, we're using it for every step of the procedure up until the very last drill and placement of the implant itself. But we already have our implant position or osteotomy well positioned before we start doing any procedures without the guide. In this case, we have adjacent teeth, which makes this pretty simple. All we have to do is establish a proper angulation and get our implant right smack in the center here, and this should be pretty straightforward. So for us, we don't use a surgical guide typically in this situation, but if we were placing consecutive implants, we would have some sort of a surgical guide. If we had a edentulous distal extension, no posterior molars, again, we would use a surgical guide to make sure we get our placement right. Placement's especially critical with molars because the potential for increased overhang off the side of your implants is much greater. For example, what do I mean? The collar of a 5mm implant is 6 millimeters. The average mesiodistal width of a molar, be it maxillary or mandibular, is 10 millimeters. So 10mm tooth diameter, or width rather, with a 6mm collar means that we have 4 millimeters of overhang. So if we get our implant smack in the center, then we have 2 millimeters of overhang on each side of our implant, which is acceptable. More than 2 millimeters is very undesirable. So if we don't get our implant perfectly positioned and perfectly angled, the amount of overhang of these crowns can become a real challenge and a problem. So again, surgical guide, I think, is more critical, believe it or not, for molars than it is for anterior teeth. In the anterior, we are obviously using it to make sure that our aesthetic setup is optimal, but for a single tooth implant that's not a distal extension, typically we don't use a surgical guide. So that's what we're going to see today. We're going to freehand our implant placement with no guide.
Perfect. Thank you, Dr. Fields. I think the patient's here, and we're about to anesthetize the patient and get started.
All right, let's do it. A lot more load than any other tooth.
So it could be probably something with drilling, or maybe too high speed on the implant motor, maybe, or something like that.
I would say that after the time of surgery, the reasons for failure are patient has the opportunity to function on it and is eating hard foods on it, or the other big thing that we see is over-torquing the implant. These are parallel-walled implants or cylindrical implants. They're designed to be placed under a low torque. And by that I mean a maximum of 30 Newton centimeters. I would say 35 Newton centimeters is the absolute upper limit. So that's not the ideal torque placement, that's the upper limit. So if you placed an implant and it didn't get higher than 15 Newton centimeters of torque as you're placing it until the shoulder seats, there's no problem with that. As long as our implant's not loose in there, has lateral mobility to it, then we're good. So primary stability is helpful in helping that implant overcome an assault by food particles, but other than that, we don't really need high primary stability unless we're going to immediately load this implant. So if we're putting a series of implants in an edentulous patient with cross-arch stabilization and we're trying to do immediate load, then we would want something that has an implant with high primary stability, and we would select an implant that's designed for that. But these implants are not designed for that, and since we're primarily doing single tooth applications, no implant's really designed for that has a low failure rate. So for these implants, when we're doing single tooth restorations, we don't want to torque these more than 30 Newton centimeters. They're ceramic. We don't want to create high shear stresses in small areas. We don't want to do that with any ceramics. But with this one, it gives us no advantage. So to place your implant under high torque is going to cause increased patient pain. It's going to cause by compressing the bone, and it's going to create an avascular zone further from the body of the implant, and this is going to increase our failure rate. And we've heard from doctors again and again who've placed these implants and similar ones under high torque and had big failure rates, and the only thing they changed in their practice was placing these implants at a lower torque setting, 30 Newton centimeters or less, and we've seen their problems totally go away. And I can show you email after email of doctors that have written me with this exact comment.
Right, cool. And so this is the Z Systems kit?
Yep. Here's their surgical kit. And they start off with a round burr, which usually I kind of skip the round burr. If we follow the yellow line, that's the drilling sequence for a 3.6 millimeter diameter implant. I haven't discussed that one because it's a one-piece implant system. And the truth is we don't place a lot of those. We focus on the two-piece implants here for a whole lot of reasons. And mostly it's to increase our surgical success rate. After we place these implants, we have a very low failure rate because it's very hard for the patient to function on these implants. So if we follow the red pathway here, that's the one we're going to follow today. We're going to skip the round burr. We're going to start with a 2.3 millimeter diameter pilot drill. Then we're going to enlarge our osteotomy with a 2.85 millimeter drill. And then we're going to go to 3.75. And then the last two drills are a countersink drill or a cortical drill. Again, to provide a little bit of relief of the crestal cortical bone to allow proper seating of the implant shoulder. And then we have the tap. And the 4 millimeter tap is, a lot of implant surgeons aren't used to seeing the tap. When implants were mostly cylindrical or parallel walled implants, almost all systems had taps. Now, many of the implants are designed to be self-drilling and self-tapping, so you don't see the tap in a lot of systems. But with the parallel walled systems that don't have self-threading, self-cutting implants, then we do need this tap. So regardless of the bone type, we generally will use the tap. If we were going to place a 5 millimeter diameter implant, the first 3 drills we'd use the same. We follow the green line, and we would go 2 more twist drills up before we finished off our osteotomy. We also have a couple paralleling pins in here. We have implant placement instruments in here, and a drill extender in here that we'll use. Also for the tap, we have this instrument right here, and this is the instrument, this is the adapter that we'll place into our handpiece that allows us to use the tap. So the tap goes into this adapter, and it's a pretty long assembly, truthfully, but you'll see, we'll be able to tap this with no problem. So all the drilling that we're going to do is at 800 RPMs, and we could do our drilling at 800 to 1200 RPMs, and anywhere in there would be fine. And again, when I'm stepping on the foot pedal for an electric handpiece, a lot of times I'm not stepping all the way on the foot pedal, so our true speed is actually less than that. And then the only time we're going to change our speed is when we tap. When we use the implant tap, we're going to do that at 20 RPMs. And then when we back the tap out, we'll have it in reverse at 20 RPMs. So when we put the tap on the drill, we're going to double check it before we put it in the patient's mouth, just to make sure we put it down to 20 RPMs. So that, in a nutshell, is a surgical kit, plus the torque ratchet, the placement device. This is how we place our implants. You might notice right next to the ratchet, we have a pair of abutments, actual restorative abutments that we keep in our kit. And again, it's once we place our implant, we use the straight or the angled abutment to confirm proper placement of our implant. Make sure that the height is good, that we have enough vertical clearance, and to make sure that our implant positioning is good. So as we start our osteotomies, we'll use the paralleling pin or guide pin to orient our osteotomy and make sure it's good. And then when we're through, we'll do the same thing essentially with the restorative abutment. All right, let's make an osteotomy. All right. is I'm going to go in at a little funky angle just to get a pilot hole. And then once I've established the pilot hole, I'm going to take my implant drill back out, and then I'm going to reorient for the real angulation that I want. And now we're off to the races. So even though we're placing a 10 millimeter implant, we saw that we actually have a little extra vertical space. As I'm drilling, I always like to clean off these drills. I like to keep everything on our tray clean. I like to keep the drills clean. If we're doing an immediate extraction, the tooth never goes onto our surgical setup. It goes in the trash, biological waste. But we don't do anything to contaminate our tray to the best of our ability.
You may have said this, but what are your RPM settings on your implant motor when you're doing this?
I'm not telling you again. No, yeah, we set it to 800 RPMs. 800. Anything between 800 and 1200 is probably fine. And nice thing, these are all ceramic drills as well. And these all ceramic drills are very sharp and they stay sharp. So,
how do you find the lifespan of the drills are a lot longer than a titanium drill?
Much longer. In fact, these will go and go until we eventually wear off the laser markings on them, the lines. And we've been placing zirconia implants, all zirconia implants, for 10 years.
10 years, wow.
10 years. These systems got FDA approval in October of 07, and we were one of the first 2 doctors to place them. And we've been placing them ever since. In fact, we've placed a lot more now than we did then, because the system's in its 5th generation. As far as placing, is using ceramic drills, we've used ceramic drills ever since 2004.
Oh, so you started with ceramic drills before you started with ceramic implants?
Yes, there was another company that had ceramic drills. I believe they got those in 2004. And yeah, we've enjoyed our ceramic drills ever since then. So we have kind of a tight fit here for our countersink. We've gone through our 3 twist drills. We're using our countersink drill. And the good thing about a tight space here, you can probably see I'm right up against both teeth with this countersink, which means that our implant osteotomy is smack right in the center. I mean, we could not have it more in the center. We're literally touching both teeth. So we've used the countersink. There's a little bit of creativity in using the countersink here. We're not going to use it a whole lot. And it a little bit depends on what the ridge form looks like. If the ridge form, if they've lost a lot of ridge height, then there's not a lot of need for the countersink. So what we're going to do now, we've gone through the 3 twist drills, gone through the countersink, and now I'm going to change the speed on my implant handpiece from 800 RPMs down to 20.
Oh, so you're going 800 to 20 RPMs.
Down to 20 RPMs, and the reason is to use the tap. The tap is what threads the hole, and we want to thread the hole very slowly. So we're going to use this instrument right here. This is our adapter. We're going to place the adapter in the handpiece. And so there's our adapter in the handpiece.
Oh, let me get that little...
With the black O-ring on it. And then the taps are color coded. There's a red ring on this one for a 4 millimeter tap. There's a green ring for the 5 millimeter tap. There's a yellow ring for the 3.6. So this is the 4 millimeter tap, and the first thing I'm going to do is I'm going to run it outside the mouth. And the purpose of that is to make sure that I remember to scale it down to 20 RPM. The last thing I want to do is put this in the implant osteotomy running at 800 RPM. That would be a disaster because we would strip out the osteotomy. So we have our thing down to 20 RPMs. We're going to go to the patient's mouth here. And again, it's a pretty long assembly, but not really a problem here. And now we're going to kind of use a little bit of muscle because this tap likes to walk around just a little bit. Pretty much all taps do. We're going to sink this down close to the bottom of our osteotomy. In this case, we're probably going to take it all the way. Typically, we'll send the tap down about 3/4 of the way. And now, I'm hitting reverse, and now we're going to reverse the tap back out. So our handpiece gives us a little auditory confirmation that we're in reverse. So I can't see the numbers, but I know we're in reverse even before I see the direction. You hear it. So we backed our tap out successfully. And now we have a fully prepared osteotomy. So everything goes as anticipated. We shouldn't really need the handpiece anymore. So at this point, can we see Marie over here?
Yes.
So she has our implant. We can confirm it's a 4x10. It says Z5C-40-10. So we have a Z5C. 40 stands for 4 millimeter diameter. 10 is the length. So she's going to peel open this peel pack, and she's either going to dump this container on our tray or I'm going to pick it out because this is sterile. The outside of that pack is not. So we're going to take our container here. We're going to open the peel pack, and we're going to flip this little lever there to expose our implant. This is plasma autoclaved implant, so the implant has to be loose in here. So they've come up with some clever packaging to allow proper sterilization of the implant and pretty easy access to it. So what I'm going to do is my placement instrument just snapped right in there. Can you see that?
Mm-hmm.
So I'm going to not touch the implant, and I'm going to get the surgical ratchet. So it says out on this side, and the other side says in. So what I'm going to do is the outside is going, the out one is going to face our implant, just like this, and we're going to. This is what we're going to take to the mouth. So hold that for me. Get your system to hold the retractor. So my implant's snug into the placement instrument, and the placement instrument is in the ratchet, and your ratchet should be preset to about 30 Newton centimeters. And I'm just going to transfer this to the mouth, and now I'm going to, now here on this side of the ratchet I should be reading in. It should say in, and I'm going to hold my finger right there. Hold my finger right there and put a little bit of pressure on it, and make sure we're going in at the right angle here. Is that good, Elizabeth? We good?
Yeah.
I don't know how to do this with your head not in the way. Joe, got a pretty little head. Yeah, Marie and Isbeth do all the implant surgeries with me, and there's no substitute for a great assistant.
We got a question from someone. They actually want to know about the implant price and drilling kit. We have one of the representatives from Z Systems here with us, Kelly. Kelly, can you give us an idea of what they can do and get that information?
Absolutely. You can go to our website, or you can contact one of our reps to get information on pricing. We always have promotions and specials. Zirconia implants take a lot to manufacture. It's not like a titanium bar that's quickly milled. and sterilized in order to have the processing that allows the structure to be as solid as it is. It's quite an endeavor. And then we also are the only company to plasma sterilize. So we have those benefits as well.
So our implant's placed, and it looks really good here. So we can simply retrieve our instruments. Again, this is a tissue level implant, not a bone level implant. The collar is not meant to be buried all the way to bone. So our collar is sitting above the bone, and all we see is smooth surfaces around the sides. We have no thread exposure on this particular implant. If we do have some buccal thread exposure on a zirconia implant, unlike with a titanium implant, we really don't care because they wind up doing absolutely fine. So again, it allows us to pick the diameter of the implant based on the ultimate restorative result that we're looking for, more so than just how much bone we happen to have. So here's our implant placement, which looks really good. And we're going to try in a straight abutment, straight restorative abutment. There's our straight restorative abutment. Take the bite block out, have the patient close down.
Beautiful.
Good patient. Close down one more time for me. Okay, let's see. Get another instrument here. There we go. Close down for us one more time. And then there's our placement.
Oh, can you open up a little bit for us? There we go.
All right.
Very nice.
There we go. It's exactly what we're shooting for.
Great job.
Can't beat that.
About how many of these ceramic implants have you personally placed?
Oh, 1,000 and change.
Wow. It's incredible.
All right, so what we're going to do next is we use a perioprobe type instrument to attach our healing cap. This is our healing cap, and what we found nice about this, using the perioprobe, our healing cap stays steady here. It's not just, there's a little groove in the top of the healing cap, and we use that to stabilize our healing abutment. So if we found that if we just put this in our fingers, it's really difficult to get it seated. If we use the Explorer end of this instrument, it's too skinny, it spins around, but the perioprobe is just perfect. You can see I have absolute stable grip of this thing, and then placing this should be a piece of cake. Even I can do it. So put the cap in, and
What kind of surface is on zirconia implants, Z-Systems implants?
Z-System, these implants have a blasted surface that increases the surface area over a machine surface about, well, quite a bit. And then in addition to that, the outer portion of the threads of the implant are laser modified. The lasers used to prep the threads of the implant, and between the blasting and the laser modification, that increases the surface area about 150-fold from a machine surface.
So how would you compare osseointegration from ceramic to?
Very, very similar, to be honest with you. Again, all the studies in animals, mini pigs, dogs, etc., would confirm that, especially at later time points, like the time point where you want to restore the implant. But let's just say they're so similar, our treatment protocol's the same thing. So if we place an implant like this, we're going to, even though we're in the maxilla, we're going to wait 3 months. 3 months, we'll have this patient back and we're ready to restore this implant. So maxillomandible, 3 months. If we do an immediate extraction implant placement, we have them back in 3 months to restore the implant. So regardless of whether it's the immediate case or not, whether it's maxilla or mandible, 3 months and we restore these based on how long it takes them to integrate to get that secondary stability that we're really looking for.
So the laser modified implant is really a unique feature.
Yes, it is. They're the only company that does that. And again, they came up with this because you can't really treat the surface of a ceramic like you treat the surface of a metal. So they came up with a very clever strategy to increase the surface area on what at the time was a novel implant material.
What suture are you using here?
We're using 3/0 chromic gut, which is a resorbable, and it'll be here for about a week. And when we see a patient a week or two post-op, sometimes these sutures are still there, sometimes they're not. If they're not, that's perfectly good. It's partly why we use them, because we're lazy. We don't want to have to take them out, and the patients like it when we don't have to take their sutures out. If they come back a week or two post-op and their sutures are still in, then the next question is, are those sutures doing anything useful? Are they loose and accumulating plaque, or are they still holding some inflamed tissue in place and doing something constructive? And based on that, we'll make a decision on whether we want to take them out or not.
Now, when it comes to, let's say, implant infections, do you notice a comparison of this compared to titanium, like a major difference there at a rate?
Our success rate for these has been very similar to our success rate for titanium implants. As far as infections are a pretty rare reason why an implant fails if you're treatment planning them properly. But we'll find the main thing is just that they fail to osseointegrate for both titanium and ceramic. And again, I think the problem often is patient function. For example, if you design a flipper, patient wants to wear an interim prosthesis, and that flipper bangs on your implant, well, even though you did this great implant surgery, the reason your implant's going to fail is because you were a little sloppy on the adjustment of the flipper. The devil is in the details. So the occlusion of your crown, the quality of the implant placement, the quality of adjusting your flipper. These little details are the things that are going to make you have failure. And that's why when you read the implant literature is not reliable. It's not reliable because you don't know the details of the techniques that the authors really did. And the technique they say they did, what they're telling you is the implant they tried to do. The fact is, they may not have done it well. You don't know. So why implants fail? I'll tell you, most implants fail because we as operators did something wrong, myself included. That's the main reason implants fail.
And can you prep this implant or the abutment?
Yes, you can prep the implant and the abutment, and that's one of the beauties of the system. So when you think tissue level implant, I don't want a tissue level implant. Let me tell you, you should want a tissue level implant because they're much easier to use. And what makes people not like tissue level implants is because in the past it was a metal implant, and the top of that metal implant was right at the top of the tissue. So if you lost any tissue height, you had a aesthetic nightmare. If you didn't lose any of the tissue, you could still often see the collar and part of the implant through the tissue, and it's aesthetically very troubling, especially in the smile zone, obviously. So the beauty of this implant is before you prep it, you can't see any of the implant under the tissue. Even spectrophotometric analyses show that this implant's invisible through soft tissue. And then the ability to prep it means we can modify the top of it exactly like we would modify a tooth for a crown prep to get that ideal crown that we're looking for. And again, it's a restorative driven specialty. So we do crown down design. We design what it is we want from our implant placement, our implant selection, based on what tooth we're trying to replace.
So tissue seems to really like ceramic. Why is that, in your opinion?
That's a good question. In the literature, you can find certain literature that'll say anything, but I'll tell you one topic you can't find any argument about is plaque and bacteria retention on ceramic versus any other metal surface. Titanium is a good example. So when we look at titanium implant surface, it could be a titanium disc, it could be whatever you want. In vivo, in vitro studies, they all agree that plaque and bacterial adhesion is significantly less in on these ceramic surfaces as compared to a titanium surface. So again, when you have less plaque and bacterial adhesion, guess what? A cleaner surface results in more healthy tissue, which periodontically we've known all along. So we finally have an implant that supports healthy tissue. Why would you not want to use it?
So it really kind of validates the cost there in comparison to a titanium in a sense. Even though when you really break it down, the ceramic can save you a little bit, but in realistically, the cost to manufacture the product, things like that.
The cost is more expensive to manufacture, but the truth is, compared to other implant systems, this doesn't cost any more than it does to use other systems. So what is the Z5C implant? It's $470, and the abutment's $180. You add that up, and you're under $700. Look at Nobel, Straumann, Astra, Zimmer, BioHorizons. You can't do an implant, an abutment, impression coping, analog, healing cap. You can't do that for less than $700.
Now, do you need any special instruments for cleaning around the implant like you do with titanium?
Not really. You don't have an instrument that is sharp enough or strong enough to damage these surfaces. Not a hand instrument.
Do they have a bone level implant Z system?
Not yet, they don't. Maybe in the future. And the other thing I would tell you about, these implant surfaces are very impervious to hygiene methods. I don't think you want to use an ultrasonic scaler around them. I think that would be a bad choice. But one neat thing is you can use a laser or an electric artery unit around these, because ceramics are very poor conductors of heat and electricity, and that's not true of titanium. So another advantage of these, if you want to laser recontour the soft tissue around it, go for it. If you want to use an electric artery around it, go for it. There's our final implant placement right there. And what I think is important to notice, our placement's spot on. We're using the healing cap here to help keep our soft tissues retracted. And if you look on the buccal, the thing that makes me happiest of all about the surgery is look at this attached tissue on the buccal. All this tissue here came from the ridge crest. So by making our incision a little bit to the palatal, it does make suturing a little bit more difficult. It definitely does make those two sutures a little bit more complicated. But in the end, the result is we have this beautiful attached tissue. So she's brushing her crown down the road, she has tissue that's going to resist that. So then we put two sutures up a little bit higher to close the limbs of our releasing incision. And I think it's clear that our incision is wider at its base than it is at its top, and that we didn't cross over adjacent tooth roots. So pretty good basic surgery. This is a pretty nice result. She obviously has a little tissue recession on her adjacent teeth here, and we'll talk to her about not trying to brush the white off her teeth. So we'll have you close down one more time. And there's our final result. Can we see that? Open one more time.
That's wonderful. We really appreciate you letting us do the surgery, and thank the patient for letting us educate the world on this system. It's been great. I know that Z Systems is really honored to do their first live surgery with us, and I think the intention is to do a lot more in 2018 with them and educate people worldwide. And Dr. Fields, I'm sure you'll be on our platform several times after this. We really enjoyed it, and we got a lot of great questions. So,
All right, thank you very much.